Hello everyone. In this video, we're going to be learning about acute suppurative otitis media. So here, acute refers that it lasts for short period of time. Suppurative means pus forming, and otitis is inflammation of ear, and media refers to middle ear. So it's an inflammation of middle ear where there is formation of pus, and it lasts for a short period of time. So generally, it is less than 3 weeks. So acute suppurative otitis media is an acute inflammation of middle ear by pyogenic organisms. So let's see what are these organisms. The most common is Streptococcus pneumonia, which accounts for around 30% of the cases. Haemophilus influenza accounts around 20% of the cases, followed by Moraxella catarrhalis around 12%. Another least common organisms are Streptococcus pyogenes, Staph aureus, and Pseudomonas aeruginosa. This disease is more common in infants and children of lower socioeconomic group. Typically, the disease advances as viral infection of upper respiratory tract from where the pyogenic organisms invade the middle ear. Let's talk about route of infection. The most commonest route is via staging tube. So in this picture here, this box represents the middle ear. We know that middle ear is kind of like a cube-shaped structure where it has 6 sides. It has a roof, a floor, anterior wall, posterior wall, lateral wall, and medial wall. The anterior wall of the middle ear is connected with the staging tube, which connects the middle ear cavity to nasopharynx. So this is the staging tube connecting nasopharynx to middle ear. So if there is infection in nasopharynx, this infection can easily spread from the staging tube into the middle ear cavity, and this is the most commonest route. So the infection travels via the lumen or subepithelial peritubal lymphatics of the staging tube. And as I've mentioned, it is common in infants and children, and the reason for this is staging tube in infants and young children is shorter, wider, and more horizontal. Hence, the organisms can easily spread from the nasopharynx. Also, breastfeeding or bottle feeding in young infant in horizontal position also force the fluids through the staging tube into middle ear. Hence, it is required to keep the infant propped up with head a little higher during breastfeeding or bottle feeding. Swimming and diving can also force water through the tube into the middle ear cavity and cause its infection. Next route is via external ear. We know tympanic membrane separates middle ear from the external ear. So when there is traumatic perforations of tympanic membrane, the infection can easily spread from external ear to middle ear. Next route is blood-borne, where the infection can travel through blood vessels, but it is an uncommon route. Let's talk about predisposing factors. Anything that interferes with normal functioning of staging tube predisposes to middle ear infection. It could be common cold, upper respiratory tract infection, infections of tonsils and adenoids, chronic rhinitis and sinusitis, nasal allergy, tumors of nasopharynx, and cleft palate. So now coming to pathology and clinical features, where we'll see how the disease advances itself. So the first stage is stage of tubal occlusion. So coming to this picture here, staging tube connects nasopharynx with the middle ear. First, when there is infection in the nasopharyngeal area, the infection can also spread to the nasopharyngeal part of the staging tube. When this happens, there will be edema and hyperemia of the nasopharyngeal end of staging tube. This will block the lumen of the staging tube. If the lumen is blocked, no air can travel from the staging tube into the middle ear cavity. So when no air can pass, the remaining air in the middle ear cavity will also get absorbed. We know that middle ear is an air-filled cavity. So when there is no air inside the middle ear, the tympanic membrane, which lies on the lateral wall of the middle ear, will get retracted towards the middle ear cavity, and this will lead to various symptoms. So first, there will be infection of nasopharyngeal end of staging tube. There will be edema and hyperemia of nasopharyngeal end of the staging tube. This will block the tube, causing no airflow to middle ear. So there will be no airflow to middle ear, and This will create a negative intratympanic pressure inside the middle ear cavity, and what this pressure does is that this will retract the tympanic membrane. So we know that tympanic membrane separates middle ear cavity with the external ear. And in the external ear, there is atmospheric pressure that is pushing the tympanic membrane in this direction. In the middle ear cavity, to counteract this pressure, there is airflow that is coming from the staging tube. So when there is blockage of this staging tube, there will be no airflow and the remaining air will also get absorbed. So the only force acting on the tympanic membrane will be the atmospheric pressure from the external air. This will cause a retraction of the tympanic membrane towards the middle ear cavity. So the symptoms we can see in this stage are mild deafness. We know tympanic membrane is responsible for conduction of sound from external ear to middle ear, so there will be mild deafness and earache or pain in the ear. When the tympanic membrane is retracted, there are also some sensory nerve fibers that will get stretched and this will cause pain in the ear. But we don't see any fever in this stage. Some signs includes retracted tympanic membrane, prominence of lateral process of malleus, and when you do the tuning fork test, there will be conductive deafness. Next is the stage of presuppuration. When the tubal occlusion is prolonged, the pyogenic organisms will invade the tympanic cavity. There will be hyperemia and inflammatory exudates in the middle ear cavity with congested tympanic membrane. So when the tympanic membrane is congested, the symptoms will get elevated. So there will be marked earache, the deafness and tinnitus will increase, and there will also be fever. Signs include congestion of pars tensa, which is also a part of tympanic membrane, lease of blood vessels along the handle of malleus and at the periphery of the tympanic membrane will give it a cartwheel-like appearance. So there will be dilated blood vessels around the handle of malleus, which lies in the center of the tympanic membrane, and also the vessels will get dilated around the periphery, which will give it a cartwheel-like appearance. And again, at this stage, when we do the tuning fork test, there will be conductive deafness. Next is the stage of suppuration, which is marked by formation of pus in the middle ear cavity. The tympanic membrane bulges to a point of rupture, so it will get so much congested that it can rupture. Symptoms here includes excruciating earache, the deafness increases, and fever of around 102 to 103 degree Fahrenheit. Other symptoms includes vomiting and convulsions. Signs here: red and bulging tympanic membrane, which is often described as angry looking tympanic membrane. There will be loss of landmarks, and a yellow spot on tympanic membrane, which is very likely to rupture, is seen. So a yellow spot is a pus-filled protruding area on the tympanic membrane. It's a nipple-like protruding area, which is very likely to rupture. And when you do the X-ray of mastoid, we will see clouding of air cells because of exudates in the mastoid air cell system. Next is the stage of resolution. If the disease is severe or if the treatment is late, the tympanic membrane might rupture. This will release the pus and the fluids inside the middle ear cavity, and the symptoms will decrease. Also, the inflammatory process begins to resolve. But if the disease is mild or if the treatment is started in time, there might not be rupture of tympanic membrane. With evacuation of pus from the middle ear cavity, the symptoms such as earache and fever will come down. In signs, the external auditory canal may contain blood-tinged discharge from the middle ear cavity after the perforation of tympanic membrane. And we can also see perforation of tympanic membrane. Hyperemia of tympanic membrane begins to subside with return to normal color, and also the landmarks can be seen. Lastly, the disease can go into stage of complication if the treatment fails or if the virulence of organism is high. There will be no resolution of infection and the disease will spread beyond the confines of middle ear. So the disease can spread into the adjacent structures of middle ear. And the complications include brain abscess, facial paralysis, labyrinthitis if the disease spreads to inner ear, acute mastoiditis, meningitis, extradural abscess, and subperiosteal abscess. You can remember these complications with the mnemonic big flames. Now coming on to the treatment section. The treatment includes antibacterial therapy, where we give penicillins such as ampicillin with dose 50 mg per kg per day in 4 divided doses, or amoxicillin with 40 mg per kg per day in 3 divided doses. If the patient is allergic to penicillins, cefaclor, cotrimoxazole, or erythromycin can be given. For beta-lactamase producing bacteria like Haemophilus influenzae and Moraxella catarrhalis, amoxicillin clavulanate, cefuroxime acetyl, or cefixime can be given. Antibacterial therapy must be continued for at least 10 days till the symptoms resolve. Even if the symptoms resolve before 10 days, this therapy must be continuous for at least 10 days, because if there is early discontinuance or inadequate doses, this can lead to secretory otitis media. Next treatment is we can give nasal decongestants. These will relieve stitch tube edema and promote ventilation of middle ear. Drugs such as ephedrine, oxymetazoline, and xylometazoline can be given as nasal drops, whereas pseudoephedrine is given as oral nasal decongestant. If there is pain or fever, we can give paracetamol. Myringotomy is incision of tympanic membrane to evacuate pus or fluid from the middle ear. In this picture, you can appreciate a small incision is given in the tympanic membrane. A small tube is fixed here and the fluid is drained from the middle ear cavity. So the reasons for doing this procedure are draining ear fluid trapped in ear for more than 3 months or 12 weeks. Treating chronic ear infections not cleared up with antibiotics. Restoring hearing loss caused by fluid buildup in middle ear cavity, or for testing fluid for bacteria. So these are the treatment of acute suppurative otitis media. So lastly, all cases of acute suppurative otitis media should be carefully followed till tympanic membrane returns to its normal appearance and conductive hearing loss disappears. Thank you.